Welcome to Doctors Unscripted. I'm Dr. Tania Small, and I'm here to bring you into a different kind of conversation with some of the brightest minds in medicine and research. How do we respond when a person diagnosed with schizophrenia commits a crime during a psychotic break? Do we see a criminal or a human being worthy of treatment, dignity, and a second chance at life? Our guest today, Dr. Ilan Melnick, is challenging every assumption we've held about severe mental illness, justice, and rehabilitation, with a 90% reintegration success rate and 0% recidivism. Today, we'll explore psychosis on trial, rehabilitation and evidence-based care, rights reclaimed, and compassion unlocked. We'll step inside Passageways, the largest forensic community control facility in the U.S., a pioneering model built not on confinement, but on trust, empathy, and comprehensive care. A place where individuals once labeled as criminals reclaim their future. And here's the remarkable part. There are no locks on the door. That's right, no locks. Dr. Melnick will show us why these individuals don't just need care. They deserve to be seen, treated, and unlocked. Now let's get started. Thank you so much for joining us here at Doctors Unscripted.
Thank you so much for inviting me. I really appreciate it.
So I have a lot that I want to get from you.
Talk to me.
The first question is, when you were in med school, actually, let me take a step back. When did you know you wanted to be a psychiatrist?
Great question. So my path really didn't start with psychiatry. When I was in medical school, I loved working with my hands. I thought it was just really cool to be in a controlled environment, and really thought surgery. Actually went and started a residency in surgery and ophthalmology at Harvard at Mass Eye and Ear. And after about 3 months, realized that it was something I really hated doing. At the end, I was stuck doing refraction a lot and not something I really enjoyed. One of my mom's friends was head of Jackson Memorial Hospital crisis, and he invited me to come and see what he did. And day one, I walk in and we're like tackling people to give Haldol and Ativan to people, and I thought this was so much cooler. Really loved it, loved every moment of it, and realized quickly that this was a better fit. Quit my residency in surgery and ended up starting at the University of Miami.
Usually in med school, we can typically predict what people are going to be.
Yes.
What did people assume you were going to be?
Gosh, a dropout, I think was they were. No, in med school, I was, growing up with dyslexia was always very difficult for me to kind of imagine myself doing anything that had to do with reading a lot and managing those kind of patients. Yeah. So I think surgery was where people really thought I was going to do well. It is something that I learned early on when doing psychiatry. Yeah. That my ability to recognize patterns really was helpful in being able to become a better psychiatrist, being able to recognize how people think, and realizing that neurotransmitters do play a role in that, and being able to figure out what neurotransmitters were either too high or too low, and being able to manage it was something I thought was so cool. Yeah. And so, although yes, surgery was something that I really thought I loved a lot, I realized that this is really my true calling.
So talk about a little bit, what kind of psychiatrist are you? I know you, I learned a little bit about forensic psychiatry. Yeah. Can you tell us a little bit about that?
Yeah, sure. So I'm one of these, I have a lot of different types of practices. Uh-huh. So although I do work in forensics, and forensic psychiatry is not what you see on TV. A lot of it has to do with testifying. Mm-hmm. A lot of it has to do with recognition of patients that maybe are found either incompetent to proceed or are not guilty to reason of insanity. But the other half of my practice is working with celebrities, models, and athletes in a concierge psychiatric practice. So I get the balance of working with the, the very sick who don't think they're sick and the not so sick who think they're desperately ill, and pretty much everywhere in between.
what led you there in terms of forensic psychiatry, and then what exactly does that mean, and how does that translate to the patients that you see?
So I came into forensic psychiatry kind of by accident. I was doing a lot of a lot of testifying in court. I was talking to different types of patients, and I realized that this was a very difficult to treat population, but gave me a lot of challenge. And I was asked to cover for a forensic psychiatrist at a program, and I thought that was kind of cool. And when I had the opportunity, they asked me if I would join in and as the chief medical officer. And at the time, we only had like 25 patients, and then we managed to escalate it now. I've been there since 2008, and now we have about 130 patients there.
So take me through the process. You're in court.
Yes.
Okay, so a patient is found.
Well, let's put it this way. A patient goes and they commit a crime.
Okay, start there.
So they commit a crime. At that point, either they're competent to proceed to trial or incompetent to proceed to trial.
Okay.
If they're competent, then they go through the normal court system.
Yeah.
If they're incompetent, they have to restore competency within a forensic psychiatric facility, where they give them classes to understand the criminal justice system. And some of those patients are restorable and where they're able to become competent, and some are considered non-restorable and where they're not able to regain competency.
And how do you determine if a patient is non-restorable?
So it's usually about 5 years. So if a patient after 5 years is not able to become restorable, they kind of drop all their charges.
Interesting.
Yeah.
And you said at one point, which I found fascinating, you can tell whether someone is, I guess, faking versus truly not guilty due to reasons of insanity. How can you tell?
It all has to do with the patterns. Patients who are illogical are consistently illogical.
Okay.
So usually when patients start changing from becoming illogical to logical within conversations, we normally think very linearly, right? We think in a straight line. And what happens is that as, patients who have psychosis and they're having delusional thoughts, they may become circumstantial and sometimes even tangential. With when you're dealing with patients and asking them questions, I usually will start asking things very quickly to try to get them off beat to see whether or not the illogical becomes logical within their thought process.
Give me an example.
I will say things like, ask questions in rapid successions. What's your name? Where are you from? Where'd you go to high school? And then start going into more theoretical questions and start changing topics.
Okay.
And people who are illogical will continue in the illogical thought. Okay. People who are logical will start thinking, why is he asking me all these questions in different orders? And oftentimes that shows me that the patient is, not able to, it is not really telling the full truth of her things.
Got it.
We also look at body reactions, body tone, if they are very comfortable in the way that they're talking, even though they're talking about some illogical things, compared to people that, let's say, are trying to come up with ideas. What you'll see is that they'll start stuttering, things won't make sense. Things they say at the beginning differ from things that they say at the end. The story isn't fully developed.
Let's talk about the illogical versus it starts illogical or not straight.
Right.
And then what is your end game?
Basically, the laws in the United States say that you cannot try somebody for someone who doesn't understand what they're being tried for, or whether the court system, if they understand the court system at all.
Okay.
Reasons why we can't, people with severe mental retardation, you can't bring them to court for certain, crimes that they commit. Once they were able to regain competency, then all of that changes. They're able to come out with, they're able to then understand what the court system is all about, why they're there, what the seriousness of their charges are, what are the consequences of the charges that they had, and that's we're able to restore competency. So once you restore competency, then they go to trial, and either they're found guilty or they're found not guilty. Now, if they're guilty, then they go to jail, whatever it might be, for whatever crime they committed. If they're considered not guilty, then you have either they're not guilty because they get let go, or they're not guilty because at the time of their crime, they didn't understand what was right and wrong. They didn't understand what was happening within that that moment because of their mental illness. So patients with schizophrenia who hear voices that say that people on the bus are, aliens, and it's my job as a citizen to kill all the aliens on the bus, and so that may happen. It didn't mean that they were killing them with the idea of just killing people for, fun. It was really because of the delusional thought process that they were having. Once they get better in their delusional thought process, these people would probably not have killed those people on the bus.
So then let me ask you this question, because how do you reconcile, I guess, the ethical dilemma between knowing that this patient did not know what they were doing and really couldn't control their actions versus to the actual crime being committed? Like, do you ever walk into this ethical dilemma when it comes to that? Because you're seeing families who may have lost a loved one versus a patient.
Mm-hmm. So oftentimes in our forensic facility, it's usually directed at family members themselves. So it's usually their parents, it could be their children, it could be spouses. The idea is that usually the ones that do it because of insanity do it because there's no secondary gain or any secondary gain to do the crime. I'll give you an example of an arson. We have a patient that was cold one winter and he lit a little can on fire just to kind of heat himself up, and it caught a dumpster on fire, which then caught a building on fire. And it wasn't, he was a person with chronic paranoid schizophrenia, and he ended up having to go to prison because of that. But when he was then found, when he went out and was found not guilty of reason of insanity, he became a part of our program, and we've now been able to rehabilitate him to the point where it's not like he was trying to hurt somebody. It was just accidental that this happened. And
did he understand what he had done over time?
Yeah, so at the moment he was just trying to get warm. It had no bearing on what was going on, and if it wasn't for his mental illness, not being able to cognitively come up with good ideas or really rationalize the consequences of what was going on, then he probably would have never lit the original can on fire.
So these patients that you, I guess, come across, do you come across them once they get into the court system, or do you have patients that haven't been to court and yet they're still part of your facility?
Yeah, so to come to our facility, these people are usually found not guilty of reasons of insanity, and they are then committed to a forensic psychiatric facility, usually about 3 to 4 years while they stabilize. And after they stabilize them, then at that point they can apply to come into our program.
At your facility, I saw those paintings, and again, just fascinating, taking us through, I guess, the process of this patient's mind, that you were able to see visually. Can you just tell us a little bit about the step process that it took to get her there?
Yeah, when she first came to us, she was very psychotic, and you start seeing the disorganization of thought, and she heard voices at the time. And then you start seeing that when she finally comes into our facility, she starts learning coping skills, life skills. She's able to kind of manage herself a little better. And once her brain starts getting more organized and the paranoia starts going away, the focus of the art changes to something much more organized about people, about caring, versus the disorganization and the paranoia that you saw in the previous paintings.
Now, how frequently can you get a patient going from that level of disorganization to actually have an empathy, to have an insight? Because from what I understood, that is the hardest piece to get to.
Yeah. So in our facility, we're close to 90%. I mean, part of what we do in our psychoeducational groups is to understand the seriousness of the crimes and how their actions impacted others, and why maybe they aren't, they don't call every week to see how they're doing. Despite the fact that in their minds, a lot of them didn't know that what they did was wrong. So what we're seeing here is we're seeing that change, and we're starting to incorporate empathy and how they respond to others as a big component of their wellness. So as they move through the levels, that's one of the things that we look into, is how they're able to empathize with the seriousness of the crime, despite the fact that they were considered not guilty due to it.
You said a lot of the way this works was based on trust. And you said sometimes they leave your facility and become outpatients. How do they continue on their medication? Like, how do they continue on the regimen when they're now outpatient, not being watched?
So the first level, when they're in the outreach in their second phase of our program, they actually come in to take their medicines every day.
Okay.
And then as they kind of go and show that they're able to do things, we take away their morning. They can take their night doses at home, but they have to call in every single day to tell the staff that they took their medicines. And usually those patients are in there with somebody who's much more seasoned, and that person also monitors their pills. So there's a 360-degree view of what happens with the individual patients.
So when, again, maybe you can educate me and whoever's listening, from what I understood, a lot of the medications that are out there do not really treat cognition. They treat, to your point earlier, they treat mostly positive symptoms. But yet, what you're telling me, these patients are becoming, the cognition starts to improve, insight starts to improve. Is that the medication? Is that what do you think is allowing that to happen?
There's a certain part, when the psychosis is gone, patients are able to think a lot clearer. But also the psychoeducational groups that we go through actually help improve cognition. Everything we do has a purpose, and so they'll do puzzles, and they will do, as part of their psychoeducational, they'll do word finding. They'll, and depending on what level they are at in terms of their functioning, we're able to kind of go and find ways to challenge them mentally. Oh, wow. So we have them come up with ideas, we have them work in groups, we have them do things together to try to find ways that they can think in a group, and that way we're able to kind of get them a little bit more of a cognitive recharge. Yes. More than it is just the medicine itself.
And what I hear is also group thinking is very interesting. So they do it in a group, not just individually.
Correct. Yeah. They do projects together.
Now I'm very curious about a prison system. And how many patients do you believe are actually misdiagnosed that are in the prison system?
Vast majority. It's the Twin Towers in Los Angeles is the largest psychiatric facility in the United States. Here in Miami-Dade County, same thing. It's one of the largest psychiatric facilities in the United States. The prisons have become the new forensic psychiatric facilities, and it's really sad because these patients, when they're in the prison system, don't get the services that they really need or the help that they need, as the money is usually funneled into taking care of the guards and the people that are staffing the prison versus the patients that really need the help.
How do we get into the system and get these patients better diagnosed?
Yeah, it's unfortunate, but that happens quite a bit. I wish better training, I guess, would be the first. The reality is it's just not enough space. Psychiatric facilities have been closing down, not opening up. When they open up new ones, they're fractionally the size of what they were, the hospitals that they replaced. And unfortunately, the money just isn't coming into the people who need it.
What you do needs to be replicated, and we need to figure out how to support such type of program to really expand it.
Yeah.
We talk about rehabilitation, and that's exactly what you have done. So again, going back to the question I asked about the end goal, what does success look like for you? And then I would love to then talk about how do you get there?
Yeah. So success for me is really trying to do what I can to help as many patients as possible. I've always, I went into medicine to really be a patient advocate, not only finding the right medicine for the patient and doing it in a successful way, but the other piece here is keeping them out of hospitals, keeping their brains healthy, keeping their physical, well-being intact, and being able to teach them those life skills and coping skills so that they can go out in the community and be members of society rather than just the outcasts that we've all trained them to be.
You and I spoke about clinical trials and a lot of it being done in academia, but then you have the hands-on experience, and each patient, I think, as we spoke about before, gets more of a personalized approach. How do you do that? Like, how do you know what's the optimal treatment for each patient?
Yeah, I mean, I got to tell you, it has a lot to do with understanding the pattern of behavior and what they're doing and how they think and how early they are into the disease state. The earlier into the disease state, the better outcomes we're going to look at, right? So when you're looking at medicines and you're trying to get a patient stable, we're trained to use some of the older medicines which tend to hit a lot of off-target receptors. And what we see now with some of the newer medicines is that they're very guided, very, they're very
Targeted.
much targeted exactly to this to these receptors, and by doing so, doesn't hit the off-target receptors, which can give us some effects that maybe we weren't counting on. And so hopefully that way we're able to not only get them better, but keep them well on the medicine for a longer period of time. And we've been able to successfully manage our patients in a way that's not only good for their mental health, but by keeping them out of the hospital, preventing relapses, our patients actually do better in a healthier way long term. Medicines that have less side effects in that are newer, the way I describe it is a laser beam versus a shotgun approach to medicines.
It's funny, I think about it as I think through chemotherapy versus targeted therapy. Same thing in oncology, where I usually tell people chemo is like putting a blindfold on and just shooting, right? You're just knocking down everything versus getting very specific to get the on-target effect and less of the off-target.
Exactly.
So let's talk about relapses.
Sure.
I watched a program that you spoke on, and you explained that every time a patient relapses, it gets worse and worse and worse. So my assumption is the goal then to just, I guess to your point, get the ideal treatment early, prevent the relapse, and therefore you can actually keep their brain as healthy as possible. Like what is the method to this?
Yeah, it's exactly what you said. I mean, the earlier the intervention, the longer that they've been on medicines that help them stay stable and out of the hospital and prevent relapses, the more intact they are, not just cognitively, but functionally. And there are multiple studies that have shown how we're able to kind of manage those patients successfully and keep them out of the hospital, but also give them the cognitive reserve that they deserve as time goes on. We know that patients that have early psychotic symptoms have worse prognosis. We know that people that break later on have better prognoses. But what if we're able to get those patients stable and not have any more episodes? Well, then at that point, we're able to keep their cognitive reserve intact and be able to get them to become more functional members of society.
You took us through the patients that you treat, which were really, I guess we assume are pretty severe to get to that point. How do we get ahead of it? How do we prevent that from happening?
Yeah. Great question. Early recognition is vital.
Okay.
We tend to use medicines that really don't allow our patients to really show their wellness over time. We know that some of the typical antipsychotics, which are still being used quite a bit, especially in psychiatric facilities, are neurotoxic as per Dr. Henry Nasrallah. And we're seeing how the newer generation of medicines are not only able to get our patients stable today and to treating their positive symptoms, but also long-term minimize the chances of having some of the movement disorders, cardiovascular issues, diabetes, weight gain. And as we're able to get these patients better, we're able to keep them better for long-term.
You've seen the change in medicine over the last 10 years. Where do you see it going over the next 10 years when it comes to treating patients with severe mental illness?
Yeah, I mean, there needs to be an approach that's done beyond just giving somebody medicine and sending them home.
Yes.
There needs to be a biopsychosocial formulation to every patient that walks through your door. This is not a cookie cutter disease, unfortunately.
In terms of stigma, even when people have family members diagnosed with this, people get afraid and they're embarrassed and they're ashamed. How do we unwind that and get people to understand that this is a disease that deserves a chance? It deserves people, it deserves empathy, it deserves care. How do we change that around?
For many years, people with schizophrenia were just thrown into hospitals.
Yeah.
They were mistreated, they were locked in dungeons, they were put on insulin, they were, frozen, given seizures. I mean, so many different ways that they were mistreated.
Yeah.
We finally have resources and we need to start changing our way of thinking. The stigma is our creation, not theirs. And we need to start doing what we can to bring these patients out into the community, which is what we've done at Passageways. Being able to give patients their lives back, even though they've had mental illness, even though they've committed serious crimes, the fact that we're able to get them into community and be able to become functional members of society is something that needs to be taught and educated about. That these people are not people we just throw away into a hospital or into a hole like we used to do, but actually are able to be rehabilitated. Maybe not all, but the ones that can and the ones that want to, we gotta give them that opportunity.
So I'm gonna switch gears a bit because, you know, as most of our listeners will be practitioners.
Yeah.
And as we spoke about before, what you have done to me is remarkable. And I mean, for those who don't know, when I first heard you speak, I had a whole list of questions I wanted to ask, which got thrown away because I was so fascinated by what you did. I mean, coming into medicine, our goal is to make a difference in patients' lives. Our goal is to turn things around. And when you hear about patients who have committed such crimes being rehabilitated in a way that most people think is impossible. I mean, I'm fascinated, I'm touched. It is the way, to me, medicine should be practiced. What advice, what knowledge can you impart on people seeing patients that want to rehabilitate, that want to get them better and just don't know how to do it?
I mean, first is, I tell my residents, don't ever follow the same rut that everybody has laid down.
Yeah.
You know, everybody tries to follow the same path, and what we need to start doing is creating new paths.
Yeah.
You know, and when you come up against a wall, don't just stand there, expect the wall to move down. Go around the wall, figure out new ways. We need to start thinking outside the box.
Yeah.
And we need to start changing our mindset and putting our patients first, which we really haven't been doing for many years.
So then with that, what is your proudest moment?
My proudest moment professionally
Yes.
is really seeing patients get out from underneath a hole, underneath a rock, be able to kind of come out and be able to see the light at the end of that tunnel by rejoining society, being able to move into their own apartment, being able to keep it clean, being able to, you know, start dating. We have patients that have started to date. We've had 2 that have gotten married. The idea is that where before our limits were just the fact that, well, they have schizophrenia and we're going to have to take care of them. But we've been able to show that that's not the way this works. We're able to get some of those patients back into society and be able to become functional. And my proudest moment are the days that these patients graduate high school. They learn how to read and write, which before they were not able to do so, are able to get jobs, are able to go out and really start making something more than just a patient with schizophrenia.
Yeah. And last question, what advice do you have to give to all of us, whether we're in pharma or treating practitioners? Any advice?
Yeah, again, follow your own drum. You know, don't allow others to tell you what has to happen. If you feel a medicine is the one that's right for your patient, fight for them. Be a patient advocate. We all went into psychiatry to be patient advocates. We didn't do it for the money. So it's important for us to find ways to be able to go out and be able to manage those patients appropriately so that they can be successful patients in society. And my advice is, don't allow people to tell you no. Don't allow people to say you have to do this, this, and this. Follow your heart, follow your brain, follow your own path to be able to get to what you feel is important for your patients.
I've learned a lot from you. You've given me optimism on what we can do, what you've done. Imagine if this could be replicated.
I hope it will be.
And thank you now for taking the time to go through this experience with us. Thank you for taking us through your center. Thank you for sitting with us. This has been quite, I would say, an inspiring discussion.
Thank you. Some of our patients really respond to art pretty well. What we start learning from them is that when they're more psychotic, you start seeing some of those things come through the art. This is one of our patients. This is a woman who ended up killing her husband. And while killing her husband, you see in the top, you see a machete going through a heart. You see the X's through the heart. And you see her underneath it holding the heart up. But what you also see within the heart are the different faces that she was. You see the white face at the bottom of the heart, but you also see at the upper right-hand side a teal face as well. This was in 89, right after she committed her crime.
Oh, wow.
You see here in 2008, 2009, much more organized in her thought process. You start seeing that there's organization within the paintings and much less of the paranoia that comes out, less psychosis. So same person painting different ways, showing the wellness of her after we ended up treating her in 2008. Part of what our program does is teaching empathy, teaching the remorse.